I'm going to talk to you guys about radiation therapy. Radiation therapy can also be called radiotherapy. So radiation therapy is a type of cancer treatment where they use high doses of radiation to kill cancer cells and actually shrink down tumors. So radiation therapy will use high energy particles or waves such as X-rays or gamma rays. It can even use electron beams or protons to actually destroy or damage the cancer cells. So a little history about radiation therapy is radiation therapy has been in use for the treatment of cancer and other diseases for over 120 years. So as early as 1897, which is only 2 years after the discovery of X-ray, they actually concluded that X-rays could be used for therapeutic purposes as well as diagnostic. So they actually realized after a woman was cured of skin cancer, following a large dose of radiation, that was when they first started to realize, well, we can actually use this to treat patients. This image here is actually an original X-ray therapy machine that was used in about 1922. So you can see it looks like a standard X-ray tube. Not much safety here as she's sitting not too far from the patient with no lead on, but in those earlier times, they didn't really realize the amount of radiation they were receiving or the damage that it could cause. So radiation therapy is used for a couple of different things. So it uses high energy X-rays or ionizing radiation to stop the cancer cells from dividing. One of the things that radiation therapy is used for is the treatment of cancer. Like I had said before, the high energy X-rays are directed at the cancer to help destroy or damage those cells, the cancer cells, and to actually stop them from dividing. Because what happens is if those cancer cells can't divide, then the cancer can't grow or spread to other parts of the body. Some important facts about radiation therapy. Radiation therapy works by damaging the DNA within those cancer cells and destroying their ability to reproduce. But when the damaged cells are destroyed by the radiation, the body will actually naturally eliminate them. So radiation therapy won't kill the cancer instantly. It actually takes days or weeks of treatment before the DNA is damaged enough for the cancer to die. So it's not an instant death, it's a slow, painful death of the cancer cells. So then the cancer cells can actually even keep dying for weeks or months after the treatment is even ended. One of the big things that we are concerned about is giving high doses of radiation to the healthy cells that are surrounding the cancer cells. But the great thing is normal cells, if they're affected by the radiation, they can actually heal themselves. So they can repair themselves from the damage caused by the radiation, whereas cancer cells can't because they're not healthy. So even though we want to avoid it at all costs, if those normal cells are affected by radiation, they can usually repair themselves with minimal damage. Sometimes radiation therapy is the only treatment that a patient needs to kind of help treat their cancer, and other times radiation therapy can be combined with different treatments like surgery or chemotherapy to kind of have a full cycle of treatments to kind of kill the cancer. So radiation therapy can be used in two different ways. It can be used to cure cancer, or if the cancer isn't curable, then sometimes they just use it to reduce symptoms to make patients more comfortable, to alleviate some of that pain. So to cure cancer, the radiation therapy will destroy the tumors that have not spread to other parts of the body. But it's also used to reduce the risk that cancer will return after surgery or chemotherapy as well. So sometimes it's used in conjunction with surgery and chemotherapy as well. If it's done to reduce symptoms in the patient where maybe surgery is not an option or other treatment options are not working, in that case it's radiation therapy that they use to shrink the size of the tumor. So if something's affecting your quality of life, they can try to shrink it down to give you some relief from those symptoms. So like, for example, lung cancer. If you've got a big tumor in there, it might be causing the patient shortness of breath. That patient might not be able to be cured from that, but they can give them a little bit of relief to help them breathe easier. So they'll do the radiation therapy treatments to shrink that cancer down. They can also use it to alleviate pain. If the tumor is pinching on a nerve or something like that, it can cause a lot of pain, so maybe they can shrink it down to alleviate some of that, just to kind of help improve the quality of life just a little. The pertinence to the medical community is pretty big, actually. I mean, radiation therapy is a very important tool in the fight against cancer. And it's actually used in the treatment of as many as 50% of cancer patients. So, I mean, they're using it quite frequently because it really works. Radiation therapy can be used alone or together with surgery or chemotherapy or other forms of cancer treatments. Radiation therapy can prolong life, it can relieve pain, and it can cure cancer. It's also useful in cases where, like, the surgical removal of cancer is not possible, like when surgery may harm the patient. So, like, if the tumor is really close to the spine and if they operate, they could cause paralysis or the patient to become paralyzed, they might not be able to operate. So that's when radiation therapy can come in handy to try to treat that without surgery. Radiation therapy has a team of specialists. It cannot run with just one or two people. So they work together in the planning and delivering of the radiation treatments, and that requires a team effort. So a radiation oncologist is the doctor. They head the cancer patient's radiation therapy care team. They oversee all the treatments, and they have special training in radiation therapy. So it's not just any physician working in that field. They have to be a specialist in oncology. There's also a medical radiation physicist. They have an advanced degree in physics, and they can ensure that the complex treatment plans are properly tailored to each patient. They also oversee quality control. That's the thing about radiation therapy. There's not just one treatment. I mean, every person's cancer is different, so they have to go in and make a very specific plan just for that patient each time. So everybody kind of works together to do that. The dosimetrist, they work with the radiation oncologist and the physicist to help calculate the proper dose of radiation that they're going to give to the patient or give to that tumor. They also help implement the treatment plan by determining the number of treatments and the length of the treatment sessions. So when I think of dosimetrists, I think they're the ones that are giving the dosimetrists. They're determining what dose to give the patient. The radiation therapist is a specially trained individual who operates the systems and the computers used to deliver the radiation treatments. So they deliver the daily radiation under the doctor's prescription and the supervision. And when I say that, it doesn't really mean that the radiation oncologist is watching over them as they do it. I mean, they're running the machines by themselves, but, they're giving them the guidance of what they want. And then each radiation oncology team has a radiation oncology nurse. So they actually care for the patient. They will care for the patient's family. They give them education, emotional support. They help them manage side effects. I mean, they're even telling them, if you're nauseous, try this. These are the best creams if you have skin irritation. They're working through and educating them and giving them great tips to kind of help make everything comfortable. And they'll care for the patient during these scans while they're there too. If the patient throws up or is sick or, dehydrated, they're going to do things to help care for them at that point in time too. Radiation therapy uses gamma rays and ionizing radiation. So it uses both. Again, radiation therapy uses gamma rays and ionizing radiation. Gamma rays are a form of electromagnetic radiation, and they are another form of photons too. And then the ionizing radiation consists of particles such as X-rays and gamma rays. So we use those two forms of radiation. So we use special measurements when we're measuring radiation. So the measurement rad is the scientific unit of measure of the radiation dose that we give to patients. So for a comparison of the dose that a patient receives during radiation therapy, The patient receives several thousand rads over a very short period of time. It depends on how many scans they're getting. It could be over, a couple of weeks, over a month, over, 6 weeks. It just depends. But they're receiving several thousand rad in that short period of time. And just for comparison purposes, a modern MAM system uses, general x-ray to take images of the breast, and they're receiving approximately 0.1 to 0.2 rad per x-ray, which there's about 4 x-rays per procedure. But still, it's a huge comparison in the difference of the radiation. So with that being said, the radiation therapy is not without risks. There is a slight risk of developing other types of cancer from the radiation. But that's something that needs to be determined, and that's why each case is unique. And they must determine the best course of treatment for each patient. They need to make sure that the benefits are outweighing the risk. These are large doses. However, when you've got somebody faced with, life or death situations, if this radiation therapy is going to help them, they're not thinking necessarily or worrying about what it may cause in the future. They're worried about right now. So prep for radiation therapy is just going to be a little bit different. There isn't necessarily a prep for all the exams like NPO, things like that. Many of the radiation therapy and planning treatment sessions are similar when it comes to the lying on the table and scanning. Everyone is unique to the person, but for them, it's going to be fairly similar. The patients can prepare by removing any jewelry, clothing that can interfere with the treatment. So, if we're scanning the head, you would want to remove any earrings, necklaces, things like that. And then prior to the first treatment that a patient ever receives, they're going to actually undergo like a simulation appointment, which usually takes about an hour. And they're going to do a lot of things during that simulation, and I'll break it down in a couple slides. But after that simulation's done, the team's going to come up with a specialized treatment plan just for that patient. Contraindications for radiation treatment would be any barium study. We can't have barium in there when we're trying to do these. Nuclear medicine procedures where the patient has received radioactive material, or if the patient is pregnant, we're not going to perform radiation therapy. There might be extreme cases where they do, but I'm not 100% aware of that, honestly. So radiation can be delivered in 2 different ways, either an external beam or internal radiation. So an external beam is just what it sounds like. The beam is coming from an external source, what we call a linear accelerator. So external beam therapy is delivered by means of that linear accelerator. They're actually powerful generators that create high energy x-rays for the therapy. What it does is it focuses those x-rays and directs it right at that tumor or cancer. So it's coming from an outside source. The second type is internal radiation therapy, which is also called brachytherapy. Brachytherapy, by definition, is treatment of cancer by insertion of radioactive implants directly into the tissue. So what they do is they place like either seeds or radioactive sources with like catheters inside the patient. The exact type of treatment will depend on the location, the size, and the type of cancer. And I'll show you some more of those and go over it a little bit more in some of the further slides. So external beam therapy can be done on an outpatient basis. A lot of times it's either done in a hospital that has an oncology center or outpatient centers or clinics. So the treatment can be given up to 5 days per week for several weeks, depending on what the radiation oncologist and the dosimetrist decide is the appropriate treatment for that patient. After the patients receive their treatment, they're not radioactive, either during or afterwards. The radiation is going through their body to the tumor, but just like a standard x-ray, you're not walking out of there being radioactive. The internal radiation therapy is where that radioactive implant is placed inside your body, either temporarily or some of them are permanent. So the patient usually stays in the hospitals for a few days after that procedure has been done until the radiation levels deplete. Because the patient could actually be exposing people because they've put a radioactive substance inside of them. So they need to stay there until that level outside of the body has depleted. It'll still be working inside of the body to kind of damage the cancer cells, but people won't be able to be exposed to it. So even when they're in the hospital, they might not be allowed any visitors due to that exposure to the radiation. With temporary implants, after that implant is removed, there's no radioactivity in the body. So temporary implants usually stay in place for either a few minutes or a few days. It depends on, where it is and what they're doing. With permanent implants, the radioactivity will decrease to a safe level before the patient's allowed to leave the hospital, which is usually a few days to a week. They should stay away from children and pregnant women during that time, or even sometimes extended periods after they leave the hospital. And usually those permanent implants will become inactive after about 10 months, but they're still going to stay inside of the body. They don't go back in and get them. And I do have some pictures of what some of those permanent implants look like. So how the process of radiation therapy actually works. Radiation therapy initially is like a 3-step process. So first the patient has a CT simulation appointment. Then the dosimetrist uses that simulation information to set up a treatment plan. And then the patient completes the laid out treatment. So that's kind of the basics of this 3-step process. Again, like I said before, each individual treatment is mapped out in detail using specialized software. So for the radiation therapy to actually work or be successful, the beam needs to be aimed at the same target every single time, the same tumor, the same mass, whatever they're trying to go for, because it needs that constant radiation to damage it or kill it. So to help with the accuracy, the doctors use a couple different devices to make sure they aim at the same target. They'll either do skin markings or tattoos. So they'll actually tattoo a little dot or an X or something like that on your hand or your, head or your chest or wherever they want to make sure they aim that beam at, so they get the precise location every single time. They also use immobilization devices like casts, molds, or headrests. These are made and formed to the patient on that very initial simulation appointment so that they can help to ensure that the patient is in the same position every time. The CT simulation appointment is about 1 hour. So the first 30 minutes of that, the patient's being educated. They're going to go over the whole experience from start to finish. They're going to explain what the side effects might be, and they're going to get consent from the patient. Then what they do is a CT simulation, which is actually a CT scan, and it lasts about 15 to 30 minutes. And then what they do is they take the images from that CT simulation, and then they're used to map out that treatment. I kind of already went over that a little bit in this slide. The slides are kind of the same, so I actually said it in the previous slide, so I'm just going to skip ahead to the next one. So this is kind of a laid out diagram of what the treatment process is. So up here you've got the CT scanning, or in the CT simulation appointment. It's used to acquire the up-to-date images of the cancer. Then, after they acquire those images, they're going to localize the tumor on the image with special software. As you can see here, the tumor's circled in, red or yellow here where they want to go in for the scan. Then they're going to do skin reference marks, or they'll make the immobilization devices at that time. And then step 4, the dosimetrist is going to sit down with all the scans, and they're going to create a treatment plan with the radiation oncologist. After that plan's complete, they're going to run a virtual simulation to ensure that the plan is accurate, so they can watch kind of where the path of the beams are going to go and see if it's actually hitting the target like they want it to. After that, they're ready to start the treatment. So they'll schedule the treatments for the patient. They'll come in. They've got everything already mapped out and ready to go. They'll either use the skin references or the immobilization devices, and they'll give the patient the treatment. And like I said, depending on what kind of treatment it is, it can be every day of the week, 5 days a week for, a month, 2 months. It's just going to depend on what type of cancer is, where it is, and what the radiation oncologist and the dosimetrist came up with. This is what a CT simulator looks like. It looks exactly like a regular standard CT machine. I just put it in there for reference. These are the immobilization devices. So they're specially fitted to each patient, and it's very important that patients are positioned in the exact same spot every single time so that the radiation is directed to the same spot. That's how they're going to ensure adequate treatment. So they can use different molds to do this. So this one here in the top left is a blue mold. So this is something for the whole body or the legs. So what they do is they put the patient in that initially during that CT simulation appointment. And this is kind of like a foam. And then what they can do is they can actually let the air out of it, and it almost vacuum seals around the anatomy. So whether it's the legs, whether it's the back, whether it's the arms, and then that way when the patient lays back in it, they're in that exact same spot every single time. They can't, reposition and change. These ones are masks, and this one is the same kind of thing but for the hips. And these are ones that they do at the children's hospital that make it a little bit easier for the kids to handle. They have artists paint them and, make them cool and exciting for the kids to wear. Because this goes right over your face. So it's a little intense. It's a little bit troublesome. I mean, if you're claustrophobic, that can really bother people. When these forms, before they're fitted to the patient, they're actually flat. What happens is they put them in a warm bath of water, almost like a hot water, and then it makes them moldable, and then they actually lay it right over the patient's face and form it to them while it dries. Once it dries, it stays in that position. So what they do is they put it over the patient's face and then they clip it down to the table. That way the patient doesn't move and the radiation is ensured to be directed at the same spot every single time. Here's a image of it on the patient. So that is very tight to their skin, it's wanting to hold them in place so they can't turn their head to the right or the left or shift their head during the procedure. It's very important that they lie super still. So that can be really hard for some individuals to handle. This next one here is the tattoos and skin markings. So really what they do is they put like a Sharpie on top of the skin. They clean the skin off, use alcohol. They put a marking on top of the skin, and then they just take a little bit of a needle and kind of push some of that ink under the skin. So this dot is very faint. It's hard to see. It's right off the tip of the arrow there. They're not trying to give you a big tattoo, but just something to give an indication mark of exactly where they want to aim that beam every single time. This is just an image of some of the scanning ahead of time. The patient's on the linear accelerator scanner there, and she's pointing to where the tumor is. They've got everything mapped out over here and exactly how they want to give the treatment to the patient. So after the simulation appointment's done, when I said before the radiation physicist, the dosimetrist, and the oncologist, they'll actually use the computer models to plan that treatment. So what they do is they take the information from the CT simulation, then they compile any other studies that that patient may have had, MRIs, other CTs, things like that, and they can use those to make a 3D recreation of that patient's anatomy. So it gives them an excellent treatment plan. This is a dosimetrist workstation. They've got a couple computers with different softwares that they use to map out the planning. And this is kind of what it looks like. So they've got different slices. They've got axial, coronal, sagittal slices, 3D reconstruction, and then what they're mapping here. Over here you can see there's different layouts. They can, use a circle to kind of target the area or eliminate the area. Shows different angles that they can come in on. And this is actually showing the machine itself and how it would angle to hit the tumor. So this is one of the softwares used to map out the dose that they use. The the red is the target area where the highest level of radiation will hit. And then what they're doing, you can see here, so here's the highest level, and then the color scale as it goes down, the level of radiation is going to fade. So the blue area is getting the lowest amount of radiation, because that's the healthy tissue. So you can see each beam coming in, so it's only hitting a small portion of the healthy tissue, and then it's targeting that tumor in the red. So this is a tumor in right off of the spine. So here is the body of the vertebrae, and here's a kidney, here's a kidney. So this is where they want to target, is this tumor right here. So that's the green filled area is where the highest level of radiation is directed. And then they've got the red and green areas again where there's going to still be a high level. But then they're trying to avoid any area outside of that, especially right here where the spinal cord is. They don't want to radiate that, or the kidneys themselves. So they're trying to direct the path of the beams in without hitting those sensitive areas. So this is 3 different systems, 3 different softwares, and how they direct the radiation in. So this first one here is a 2D radiation therapy. So what it does is it exposes the patient, but all these other areas outside of here are getting radiation. So all the healthy areas here are getting radiation, and this is a head. If you didn't figure that out, I guess I should have told you that. So here's the palate, the teeth here, and the back of the skull. So this patient is actually getting radiated to 3/4 of their head. Then you have the next one, which is the 3D conformal RT. So what that does is it actually shapes to the beam to match the shape of the tumor. So you're getting less radiation to the healthy tissue, right? I mean, you're missing here, you're forming it right around the tumor itself so that the healthy tissue is saved. And that's great, it's a step up from the 2D, but the IMRT gets even better. So that's the intensity modulated RT, and what that does is it sculpts the edges to the tumor. So it uses more precision and accuracy, which results in fewer side effects and actually a higher cure rate, because they can get so much more radiation to that unhealthy cancer tissue and save the healthy tissue. It actually has a higher success rate. So this is just another mapping. So during the mapping, like I said, they can map out areas that they want to protect and have a lower dose. This image, they use the light blue line right here to outline the spinal cord, and this is an indication that they want to protect this area from the beam. The red and green lines show where the oncologist wants the highest dose of the tumor. And then the dark blue line is the entire area which is at possible risk for tumor involvement. This one here, on these 2 images, so you've got an axial slice and a coronal slice. So they're mapping out the treatment, but what they want to do is they want to avoid the kidneys, because kidneys actually have a very low tolerance for radiation. So they're using multiple planes so that the kidneys can be viewed in all angles to make sure that the path of the beams are avoiding them as much as possible. This one here, they have these little green lines right here that you can see. These are called multi-leaf collimators. So each one of these can be moved independently. So it can form shapes around the tumors to kind of help avoid the objects. So you can see here in the green and pink, these are the kidneys. So what they did is they kind of moved this collimator around. They're still getting some of the area of the kidney affected, but they want to make sure they're getting all the borders of the tumor. So they are getting as much of the kidney out of there as they possibly can. And then the tumor obviously is in red for the maximum dose. These are some 3D reconstruction treatment plans. So this is actually the pelvic area. Every time I look at this, I don't know why I feel like it looks like a turkey with the little turkey legs sticking up in the back. But this is actually a pelvic area. So it looks like you're looking at it from the feet up. The red portion here is the bladder. And then you've got a hip here, so the head of the femur coming down the leg, they've just cut it off. And then you've got the pelvis here, symphysis pubis, and the wings of the pelvis up here. So, being able to make a 3D reconstruction gives them a better idea of where the tumor is and how they want to go about treating it. This is another 3D reconstruction plan, so it's the brain tumor here, and then it's showing the path of the beams coming in here, and then trying to avoid the eyes, which again are very sensitive to radiation. So radiation therapy has different treatment options or different types of machines that they would use. And again, it's going to depend greatly on what the actual cancer is, where it is, and what they're trying to do. So they can use a linear accelerator, which is the most common machine. It's an external beam treatment. So they're powerful generators that create high energy x-rays for that external beam radiation therapy. The linear accelerators have a special set of lead shutters that we call collimators. Those can really help focus down the x-rays so they're directed right at the tumor, and again trying to save some of that healthy tissue. The thing with the linear accelerators is that the higher the energy of x-ray beam they use, the deeper they can actually penetrate in the body. So most linear, there's actually a couple different kinds, and I have a picture here in just a second, but they're a large L shape. And what that does is it allows the linear accelerator to kind of rotate around the patient, delivering radiation from different angles. And then the multiple angles will allow for the maximum amount of radiation to be delivered to the tumor while sparing the healthy tissue. So treatments with a linear accelerator can be given 5 days a week, 4 weeks at a time. Brachytherapy, like I said before, is an internal delivery of radioactive material. So they're directing it right into the tumor or wherever the cancer it is. So we can use things like seeds or interstitial irradiation, which is like putting catheters in, and I'll show you those in some pictures in just a little bit. But with internal radiation therapy, the patient is actually going to need to stay in the hospital. Remember, like I said, they're still emitting radiation, so they need to stay in the hospital until that reaches a safe level. There are some other treatment options that I haven't really talked about yet, known as stereotactic surgery. What these do is delivers a large, precise radiation dose to a small tumor area. So it's very important that the patient remains very still during these procedures. And sometimes it's given just as a single treatment. They use such a high dose that it's only one treatment or just a couple treatments. So one of them is the gamma knife. The gamma knife is not really a knife. It's just a name that they have used. It's only used for brain tumors. So the gamma knife uses concentrated radiation doses from a cobalt-60 machine, and I'll talk about that in another slide. But what it does is it takes a total of 201 beams of radiation that all come in and intersect into the area or the target area where the tumor is. So the gamma knife is very precise, and it really does a good job at damaging and destroying unhealthy tissue while saving the healthy tissue. So the tumor kind of gets the entire beam, where the healthy tissue only gets one of those 201 beams. And I've got some illustrations in just a few slides that will show you what I mean by that. So these are some of the different machines right here. The first one is the cobalt-60. Oh, you know what? I didn't talk about the CyberKnife. I'm sorry. I'm going to go back for a second. One of the other stereotactic radiosurgeries are the CyberKnife. So usually those are done in about 1 to 5 treatments. So again, less treatments than the linear accelerator. It is still a linear accelerator machine, but it's a little bit different because it's mounted on a robot arm, so it can move in so many different angles around the patient. What it does is it actually uses real-time imaging. It's capable of performing images right there in the room. So then it takes an image, and then the machine itself is directed right to that tumor or cancer, and it can move and bend around the patient. It can actually come in from thousands of different unique angles around the patient, which is huge because sometimes the tumors are in really hard to reach places, and the other machines just can't do a good job of getting to those areas. So it helps direct the radiation to the tumor while minimizing the dose to that healthy patient. So going back to this one, these are the couple different machines. So you've got the Cobalt 60 first, and then the 2 linear accelerators. So the Cobalt 60 system is not necessarily the Gamma Knife. Most of the Cobalt 60 systems have been replaced with linear accelerators. Cobalts just can't deliver the high power of radiation that a linear accelerator can. Also, one of the biggest downfalls is the radiation produced from a Cobalt 60 system cannot be turned off. So the radioactive source is always on. I repeat, for the Cobalt systems, the radiation source cannot be turned off. So the radiation is always on with those. So that's a downfall. They actually have like a big lead shutter that encloses the machine so it's not emitting radiation out, but it is a downfall for that machine to not be able to be turned off. So like I said, many of those linear Cobalt systems have been replaced with the linear accelerators because they just can't deliver that higher power and they can't be shut off. The linear accelerator machines, they produce very high intensity x-rays and they give a higher dose than the Cobalt ones. And the good thing about them is they can be turned on and off. So this is an image of an external beam radiation therapy treatment. So you've got your patient laying on the table here and they've got their immobilization device on, and then they have the beam directed right at the area where they want to treat. So that patient is going to receive that radiation treatment. So the stereotactic radiosurgery, like I said before, the Gamma Knife, it uses multiple beams of radiation, focuses on a small area. It uses about 201 beams. So here's the images that I was talking about. So this is a pretty intense procedure. This is actually mounted to the patient's head. It's actually kind of screwed in to hold it in place because, like I said before, it is so vital that the patient hold still because you want to make sure that those radiation beams are directed at the tumor. So this is like a big bowl. Well, every radiation beam is directed through one of these holes. So they all meet up in the tumor. So the patient isn't getting all of them at once. You can kind of see here. So the patient's kind of head is enclosed here with that immobilization device on, and then each beam comes through. It's only touching here, here, and here, but they're all meeting up in that tumor to give the best dose. Again, here's just a couple more views of what it actually looks like. So the difference between the Gamma Knife and the CyberKnife is where the beams can come in. So with the Gamma Knife, they can come in and be directed at the tumor, but they can only come through this helmet. With the CyberKnife, it can move around the patient at about 1,400 different angles. So you've got 200 angles of treatment versus 1,400 angles of treatment. The Gamma Knife is only done in one treatment, and then the CyberKnife can be up to 5. So I believe this video here is of the Gamma Knife, so you can kind of see how it works. I'm going to pull that up. Give me just a second. Okay.
Gamma knife surgery, from the patient's perspective. This video describes gamma knife surgery and what you as a patient will experience before, during, and after treatment. Gamma knife surgery is a well-established treatment method used to treat selected neurological diseases. Leksell Gamma Knife is not a knife in the normal sense of the word. The doctor makes no incisions. Instead, precisely focused beams of radiation are directed to the treatment area. The treatment is painless and also allows the patient to quickly return to normal routines. More than 50,000 patients undergo gamma knife surgery every year. The method has been in clinical use since 1968, and there are more than 250 Leksell Gamma Knife systems in operation around the world. Gamma knife surgery is a unique method that delivers extremely focused radiation beams to the target in the brain. The patient's head is positioned inside the radiation unit. During treatment, all radiation beams meet in a focal point, with sub-millimeter precision. The individual beams are too weak to damage healthy tissue on their way to the target area, but very powerful when they simultaneously merge at a single focal point. This can be compared with the principle of a magnifying glass in the sun. Through small pre-programmed movements of the head into different positions, the shape and dose of radiation is optimized to affect only the target, without damaging the surrounding healthy tissue. In most cases, a single treatment will be given. This will involve 4 main steps: attaching the frame, imaging, treatment planning, and the treatment itself. A specialized team takes care of you throughout the entire procedure, and the patient is, in most cases, awake at all times. Before treatment, the doctor will inform you about the whole procedure. To begin with, the lightweight frame will be placed on your head. Hair doesn't need to be cut or shaved. Local anesthetic is applied where the frame is to be attached. Once the anesthetic has taken effect, the frame will be fixed to the head with 4 pins. The frame remains on your head throughout the entire procedure to keep the head in a stable position during imaging and treatment.
Can you imagine how the patients would feel in this situation? How intense, how scary that would be to have that immobilization device put on your head and put in with pins to hold it in place. Why? So you can't move?
Attaching the frame takes about 15 minutes. A coordinate box is used during imaging to provide reference points on the images for the treatment plan. After the head frame is in place, it's time for imaging. For example, MRI, CT, or angiography. Although these imaging studies may have been done before, they need to be done again with the frame on to determine the exact location, size, and shape of the target. After imaging, the coordinate box is removed. The images are now transferred to the sophisticated treatment planning computer. Once the images have been taken, you can rest, while the doctor, often together with another specialist, develops your treatment plan. Each treatment plan is unique and individually designed to address the particular patient's medical condition. The specially designed treatment planning software assists the doctor in preparing the treatment. For added security, the final plan is rechecked and approved. Once the treatment plan is complete, the actual treatment can begin. Before starting, the doctor will explain how long the treatment will take. You will lie down on the treatment couch, and the head frame will be attached to the patient positioning system, which automatically moves the head during treatment. The number of small movements.
Remember when I said that the cobalt systems couldn't be shut off? These are the lead doors that are holding the radiation in. So you can see when they get ready to put her in, these doors are going to open to allow her to come in, but that's what's stopping the radiation from coming out into the room normally.
Depends on the shape and location of the target. The treatment is silent and totally painless, and will last a few minutes to more than an hour, depending on the target. During treatment, you will be fully awake and able to communicate with the doctor and nurse through an audio-video connection. The team is there at all times to assist you. Once treatment is complete, the frame will be removed. Some patients may experience a mild headache or minor swelling where the frame was attached, but most report no problems. The doctor will inform you whether or not an overnight stay is needed for observation, or if you can go home immediately. Either way, a patient should be able to return to a normal routine in a day or so. The doctor will stay in contact with you for periodic follow-ups and consultations.
Alright, I'll stop this one there. I'm going to go back to the machine. Give me just a second. Okay, this is a CyberKnife suite. So the CyberKnife, like I said, is on a robotic arm here, and it can move around the patient at about 1,400 different angles. See how the table is on an arm so it can move too? They've also got machines for x-rays too, so that they can go ahead and take imaging during the procedure while they're doing it for exact, precise locations. So one of the most advanced forms of radiosurgery is the CyberKnife. It's painless, it's non-invasive. It uses that robotic arm to deliver those focused radiation beams. Not beans, it says beans, but beams. The flexibility makes it possible to treat areas of the body that can't be treated by other radiosurgery. Things like the spine or spinal cord, where it's very sensitive, the prostate, lungs, pancreas, and even different brain cancers. So I have a video of the CyberKnife too. It's a little bit shorter than the other one. I'll pull that up.
I think the ability to use the CyberKnife system and perform radiosurgery in the lung represents a very big advancement.
I feel really lucky to have found CyberKnife.
It's changing the way we view cancer, control of cancer, and how we treat cancers of both the brain and the body.
The CyberKnife gave me my life back.
The CyberKnife system is the world's first and only robotic radiosurgery system. This technology brings the benefits of radiosurgery to the treatment of tumors anywhere in the body. It provides a pain-free, non-surgical alternative for patients, including those who refuse surgery or have been diagnosed with surgically inoperable or complex tumors. CyberKnife treatments are done on an outpatient basis and do not require anesthesia or invasive stabilizing frames. Most patients can return to normal activities almost immediately following treatment. The CyberKnife system uses continual image guidance and computer-controlled robotics to precisely deliver high-dose radiation beams from virtually any direction with sub-millimeter accuracy. This unhindered mobility minimizes damage to surrounding healthy tissue and nearby critical structures like the spinal cord. The CyberKnife system is a dedicated robotic radiosurgery system. Unlike conventional radiation therapy, which delivers low-dose radiation in 30 to 45 treatments, CyberKnife radiosurgery delivers high-dose radiation in as few as 1 to 5 treatments. The CyberKnife system can be used as an alternative to surgery, unlike radiation therapy, which typically serves as an adjunct to surgery.
Overall, the CyberKnife system made the biggest impression on me early on with regards to being able to offer treatments to some patients who haven't had any other options. They didn't have either a surgical option or a radiation therapy option or chemotherapy. And this allowed us now to offer them something that wasn't available before, that wasn't only effective but was safe.
Unlike other systems on the market, the CyberKnife system images continually throughout the treatment and automatically corrects treatment delivery for even the slightest tumor or patient movement throughout the body. This unique ability is important for treating tumors that move, particularly those in the spine, lung, liver, pancreas, and prostate.
A lung tumor moves constantly with respiration. Conventional radiation, you'd have to radiate the whole area where the tumor might be in any phase of respiration, whereas a CyberKnife, the radiation device actually tracks the tumor and allows us to give a very focused dose of radiation to the tumor, not the surrounding normal lung.
Unhindered by the clockwise-counterclockwise constraints of conventional gantry systems, the CyberKnife system's robotic mobility has significantly improved dose sculpting capabilities and conformal dose distributions.
Unlike the conventional radiation machines, the CyberKnife literally can dance around the room. Those radiation beams can come in from the head of the patient, the feet of the patient, the sides at multiple different angles. That's something our conventional radiation machines, which are fixed, are not capable of doing. And as a result of that, we can get very high doses into the tumor and spare the normal tissue surrounding it.
Prior to treatment, the patient is imaged using a high-resolution CT scan to determine the size, shape, and location of the tumor. Following the scanning, the image data is digitally transferred to the CyberKnife System's treatment planning workstation, where the treating physician identifies the tumor to be targeted and the surrounding vital structures to be avoided. The CyberKnife software then generates a treatment plan to provide the desired radiation dose to the identified tumor location. Finally, during a CyberKnife procedure, the patient lies comfortably on the treatment table, which automatically positions the patient. Treatment generally lasts between 30 and 90 minutes. Prior to the delivery of each beam of radiation, the CyberKnife system simultaneously takes a pair of X-ray images and compares them to the original CT scan. This image-guided approach continually tracks, detects, and corrects for any movement of the patient and tumor throughout the treatment to ensure precise targeting.
Cancer is different in different people. Different people survive because they approach it differently. And when I looked into everything I could find, that was the only thing I could find that I was going to bet my life on. And I bet my life on the CyberKnife, and here I am 2 years later.
For me as a physician, it's important to have the CyberKnife available as an alternative treatment because we're talking about treating patients who are in many ways desperate with no other therapy available to them.
I was diagnosed with cancer of the prostate just a year ago, and my reaction was one of absolute disbelief. Once I started treatment with the CyberKnife, I had to be in a room for just about an hour, perhaps a little less, for 5 days in a row. And after the treatment with the CyberKnife was finished, I rested for no more than a day and then would resume my normal activities. Now it's about 8 or 9 months since my treatment. I have no symptoms. I'm doing my full activities. I'm very active in sports. I have no complications. I couldn't be happier with the results of my treatment.
I think the CyberKnife is a major advance in the treatment of prostate cancer. The accuracy with which we can deliver the radiation to the prostate is phenomenal, and I think it's going to revolutionize the treatment of prostate cancer.
I was diagnosed with a brain tumor about a year and a half ago. It is not a cancerous brain tumor, but it's more of a disabling brain tumor that causes hearing loss, facial paralysis, and loss of balance, and can become life-threatening if it would be left untreated. The CyberKnife was the best choice for me because it allowed me to treat my tumor non-invasively.
In Suzanne's case, for the benign brain tumor that she had, CyberKnife was an excellent treatment option for her. The main reason being was that it was non-invasive, it was not a surgical procedure, it was done as an outpatient, and I think it gave her the best chance of preserving her hearing, which was at risk with any other type of treatment, whether it was another form of stereotactic radiosurgery or open surgery. So the CyberKnife, I think, was by far and away in her best interest and give her the best results.
So I like the video. It gives a little bit more detail about the CyberKnife, but I think the CyberKnife is one of the newest, latest, greatest equipment in stereotactic surgery that's really helping these patients. So brachytherapy is that internal radiotherapy where we talked about that uses different types of implants that can be temporary or permanent. So they're frequently used for cancers of the tongue, uterus, cervix, and prostate. This is just a little bit of our little diagram of the different types of brachytherapy treatment sites. Sorry, I've been talking too much apparently. So breast, uterus, cervix, vagina, skin, bladder, prostate, penis, trachea, lungs, brain, eyes, lips. So I'm going to show some pictures of different types that they can use. So how does it work? What they're doing is they're actually placing that radioactive material right into the tumor or the surrounding tissue. So they place it close to the tumor so that the large doses of radiation can hit those cancer cells and either damage or destroy them. But what it does is it allows minimal radiation exposure to the normal surrounding tissues. So they can either administer it by surgically inserting it and removing it, or leaving it in. They can put small catheters in there, right in the tumor, and have a machine that administers radioactive seeds into the catheter, and they'll stay in for a determined amount of time. Other types of sources can be thin wires, ribbons, capsules, or seeds. This next slide is an image of the seeds, so here you can see in comparison to the size of a penny how big those seeds actually are. And those are actually left in permanently. So for like the prostate here, what they show is they've got them inside a little catheter and they insert them right into the prostate gland and then they leave them in there. And this is what it looks like on a general x-ray. So you actually see patients with these in all the time. Nah, I shouldn't say all the time, but frequently. And they're left in there permanently. They emit irradiation for about 10 months and then the radiation deteriorates, but the seeds will stay in there. This is brachytherapy. This is the interstitial type. So they've got the catheters going through the breast here. They're going right through the breast. They're hooked up to a machine that's delivering the radiation, and then after the dose, they'll take those back out. And you can kind of see here on the 3D dosimetry mapping. So here's the tumor here in the pink, and then they've got all the different catheters that are going through that are delivering radiation right through that breast, and you can see that it's targeting that area. This is the same thing but on a tongue. So here is a simulation of the cancer. So you've got here where the red is where the cancer is in the mouth, and they're putting those catheters right through the tongue so that they can deliver radiation right where they need to. And you can see it's hooked up here to the machine that's actually delivering the radiation. So patient perspective for radiation therapy. I'm sure that even looking at some of these images, watching the videos, seeing some of the things that these patients go through, you can kind of get an idea of what their perspective would be. It's going to be high anxiety. You know, in some of these patients, it's life or death. In some of these patients, it's a guaranteed death sentence, but you're just trying to make them a little bit more comfortable. There's a lot of emotion that goes along with this. So, you know, patients can be upset, they can be scared, they can be nervous, they can act angry. There's a lot of different emotions that's going to go into that. There's some side effects that can be kind of hard to deal with. The side effects usually come from the radiation hitting the healthy tissue. One of the universal side effects is fatigue. People are just really tired after radiation therapy. But the side effects are going to depend on different factors. 1, the patient's tolerance. 2, the location of where the treatment is happening. And the length of treatment. The average length of treatment for most radiation therapy is 5 to 15 minutes. I repeat, the treatment time for most radiation therapy is 5 to 15 minutes. So, like I said before, different areas are going to cause different side effects. So the brain, side effects from the radiation therapy to the brain could be swelling, headaches, vomiting. The patients can be really sleepy or even have confusion 1 hour after the brain treatments. Any treatments involving 4 or more weeks can result in hair loss as well. Side effects for the face and neck, long treatment, so these are high doses for a period of 5 to 7 weeks. The patient can experience thickening of the saliva or even reduced amounts of saliva. They might lose their sense of taste, their appetite. They may have difficulty swallowing. Sometimes they'll actually use some like numbing gels to help them be able to swallow or even put them on a liquid diet. Side effects when the radiation is directed towards the chest. It can involve irritation to the esophagus because obviously the esophagus is going all the way down, so the patient can have throat pain. They can have difficulty eating any solid foods. They can have a cough from irritating the bronchioles, and their skin can become red. The abdomen side effects, are usually noticeable about 1 to 2 weeks after the doses have started, and that can be loss of appetite, nausea, vomiting. Most of the treatment revolves around taking just different anti-nausea medications. Lower abdomen or pelvis. Treatment in this area is going to always pass through the large and small intestines, so the patients can get diarrhea, rectal spasms, bladder spasms, and they'll use some different types of medications to treat these side effects. Side effects from the skin. So sometimes due to radiation, people can get skin arrhythmia. So that's redness in the skin due to the radiation. It's a lot higher of a risk in people who are fairer skin. So present day, this is the only side effect related to radiotherapy for the skin. In the past, there was a lot of different issues. They could have sores that never healed. Sometimes the tissue was damaged beyond repair. So this is kind of what it can look like here. It kind of looks like a bad sunburn. You can see in this area here. But most of the time that goes away. There are times that have long-term side effects. In the area of treatment, the skin may appear darker. It can even feel different. There could be spidery marks, like from broken blood vessels, like spider veins. Lymphedema, which is the blocked lymphatic channels. The patient could have infertility. So if radiation reaches the testicles or ovaries, the patient may become infertile. The bladder may become less stretchy, which means you'll have to urinate more frequently. And there is the possibility of radiation-induced tumors. But, those are things that you need to take into consideration. That's why I said before, making sure that benefit outweighs the risk is really important. So the cost of radiation therapy is very expensive. It's about $40,000 to $60,000 for an average of 4 to 6 weeks worth of treatment. So that's pretty expensive. Technologist perspective, obviously it's going to depend on the individual, but the one really good thing about radiation therapy is you really get to know your patients. Think about that. If you're scanning them, if you're treating them every day, 5 days a week for a month or two, you really kind of get to know that person a little bit more. So it tends to be more rewarding. You can build a relationship with them, and it's even better when that patient is done and it's working and they, have the possibility of becoming cancer-free. So it can be really rewarding. On the opposite side of that, it can be depressing. People are dying. People are scared. You may lose patients. Again, that's the downfall. You get close with those patients. You've got to know them. You've scanned them every day for weeks and weeks, and then they die. And that can be really hard for some people to deal with. It can be depressing. And then again, you're coping with people with a wide variety of emotion is involved in this. They're scared, they're upset, they're worried. So that can come out in a lot of different emotions in people. So I think the technologist perspective would vary day to day, and for each individual it would be different. Who performs radiation therapy? So we talked about that whole team of individuals, but the radiologic technologist that performs it has an associate's degree or a bachelor's degree in radiology. Now, you do not have to be a registered radiographer to do radiation therapy. There are courses where you can just go directly into radiation therapy and do your 2 years of clinicals with your didactic courses and your core curriculum. After you're done, then you would take a board exam through the AART, and your initials would be RT, and then it would be, if you weren't a registered technologist, it would just be T for radiation therapy. Career advancements are going to be all the same. You can be a manager, sales, education. Compensation is about $31 to $44 an hour. So again, depends on where you live and your experience, but they tend to have a little bit higher end. I mean, this is a very serious, detail-oriented career. So the pay tends to be a little bit higher when it comes to that. There really aren't any ethical issues because you have to be a registered radiographer. They're done in outpatient centers and hospitals, so they're very well regulated. The future of the modality is increased treatment options, advanced beam limiting devices, just better equipment that I think is going to help to limit the amount of radiation, the amount of radiation to healthy tissues, the ability to cure cancers. I think there's a lot more coming. So here, I just have a few images I'm going to try to get through real quick instead of starting a new slide. But this is pre-Gamma Knife. So this was a patient that has an MRI with a brain tumor right here. So this was before the Gamma Knife procedure. And then you have the patient after the Gamma Knife. Look how much that shrunk. And then we'll do the side by side so you can see. Look at the difference in the size of that pre-Gamma Knife and post-Gamma Knife. And here's another one too. Pre-treatment and post-treatment. You can barely see where it was. Same thing here. Big tumor right here, and the size of it shrink down. Now these could still be shrinking and dying off too. So I mean, these are just progression scans to see where the cancer, if it's actually working. And then here's one on the thyroid. So look at how large this mass was here, and then the shrinking of it from the radiation therapy. So that's the whole point of radiation therapy, is to damage and destroy those cancer cells, to either shrink it or totally eradicate it. So that's it for radiation therapy. I hope you enjoyed it.